I start in the name of Allah, who is very beneficial, merciful, and very, very kind. CME topic by Mother and Child Survival Group of Pakistan, me, Dr. Tariq, Ops Gynae Family Emergency Specialist, Internist, Gulf KSA, presently a district gynecologist. CME topic is a very common topic, especially highlighted with chronic pelvic pain and infertility and subfertility. This is known as endometriosis. Endometriosis is a common subject in the woman of the reproductive age group, as in it the endometrium is found outside the uterus, elsewhere in the body, in the various parts of it, and has the same cyclical changes of inflammation whenever the cycle comes. So when it is present, so it is present in the reproductive age group, and when there is increase in the production of estrogen dependent, it is rare after post menopause, when there is deficiency of estrogen. And so when this comes into the myometrium, then it is known as adenomyosis. There are various theories for it. Number one is for its etiology, and for its there are myths, and there are special theories. One is the retrograde menstruation with the invasion, growth, and of this menstrual tissue, and it is more than accepted in 90% of cases. It's accepted, and it is, that's why, as the blood is present in the pelvis. Second is the retrograde menstruation, and then there is of mesothelial cells, there is lymphatic, and this lymphatic spread, and then there is modification of the immune system, immunity. So these are the various theories they have been put forward, and then comes the investigations, basically the site and size, and most important is the chronic pelvic pain, which sometimes present with acuteness, and it has, so most of these cases, they are discovered due to chronic pelvic pain, due to investigation to subfertility, and then for subfertility, and then for investigation as pain, as investigation for hematuria, for bowel diseases, same the endometriotic involvement of rectovaginal and bladder symptoms due to bladder and bladder symptoms due to endometriosis, as they cyclically they bleed and present with hematuria and with this. So chronic pelvic pain, subfertility, and dysmenorrhea, dyschezia, dysuria, and all these are due to tenesmus and disturbed bowel habits. These are all due to the endometriotic symptoms. As mentioned about the pain is subfertility is important, and the pain nature is that the ratio of the prostaglandins, it is disturbed, and then there is dysmenorrhea as well, and then there is dyschezia as well. There is bleeding due to bowel involvement of the endometriosis. There is hematuria due to bladder involvement, and there is chronic long-standing pelvic pain cyclically it is disturbed and is present, and for this investigations it is being discovered through being infertility, dysmenorrhea, and for chronic pelvic pain, and for other symptomatology of involvement of various symptoms, various systems. Then comes the grading of the endometriosis. This grading is according to the revised American Reproductive Medicine, and it depends upon the site. Site is due to the common sites are pouch of Douglas, ovarian fossa, and pelvis, pouch of Douglas, ovaries, and bowel, bladder, and then these are the uterosacral ligaments, and pouch of Douglas, and posterior fornix, nodules in the posterior fornix. So this is depending upon, and then there are rare sites as well, muscles, eye, and then lungs and brain. But the commonest are, as mentioned, the pelvis, bladder, bowel, pouch of Douglas, ovarian fossa, ovaries, ovarian endometriosis, and then comes the pelvis. Then site, size, location I have already mentioned, and the size less than 1 centimeter, more than 1 centimeter, and greater than 3 centimeter. And then also depth, and depth of infiltration, and also the importance of whether the adhesions, whether they are filmy, whether they are dense. So according to these site size, location, and depth, and adhesions, they are graded accordingly. And then their number is like 1 by 3, 1 by 3, and 2 by 3, and then more than 2 by 3, and then more than 3 centimeter. 3 centimeter endometriomas, they are common. Then there are present these nodules, they are present in the posterior fornix, in the pouch of Douglas, and in the pouch of Douglas they are present as the gun minuscule of the powder burn, as red, bluish, blackish, and chocolate and pink colors they are. Endometriotic cysts are there, endometriomas are there greater than 3 centimeter, they has to be removed. And then there are other lesions also, they are present in the bladder and in the bowel, in the rectovaginal septum. And rectovaginal nodules are also there. Endometriotic nodules, endometriotic cyst, endometriotic this rectovaginal nodules, and these minuscule of powder burn, they are commonly detected by the when doing the laparoscopy, and especially in the pouch of Douglas. And then the symptoms, as already mentioned, the pain, the site, relation to its menses, and present with inflammation when the menstrual cycle comes, so they bleeds. And wherever these lesions are present, in the peritoneum as well, peritoneum, and in the ovarian, and in the bladder, and the bowel, and the rectovaginal septum, and in all these, they cyclically have symptoms of pain and inflammation, and even the bleeding, in which that presents in the bladder as a hematuria, and bleeding PR in the rectum. So these are all the symptomatology. and then come the investigation. Then on the examination you can find the endometriomas, endometriotic cyst greater than endometriomas greater than 3 millimeter, and then these are the powder burn lesions in the pouch of Douglas, and then there are endometriomas, endometriotic cyst, and the nodular nodules in the rectosigmoid. These are present. Investigations are through the ultrasound, transvaginal ultrasound, and through the laparoscopy. And the laparoscopy should not be formed, it should not be used when the patient is having the treatment, having hormonal treatment. It should not be performed it should not be done in 3 months of the treatment. And then laparoscopy is also used to find these lesions, and then can be used, endometriomas can be resected, coagulated, and cauterized and excised, and also can be biopsied. So laparoscopy is a very gold standard for diagnosing the endometriosis. And then you can do these prophylactic, you can do the diagnostic, you can do the therapeutic surgery with these endometrioma, especially the endometriotic cyst. And these are the chocolate cyst, which contains the brownish material, cheesy material. It's a diagnostic of this endometriosis. And these cheesy material are also found in the pouch of Douglas as minuscule powder burn, black powder burn. Regarding the treatment, there is it depends upon the site, size, and relationship to the hormones, and then the medical and the surgical. The medical treatment with the chronic pelvic pain, you can have the association, you can have the availability of NSAIDs, which are very effective in dealing with chronic pelvic pain, but they sometimes disturb the mid-cycle ovulation. And then comes the hormonal treatment, another treatment which is available, as most of these are used as an ovarian suppression of ovarian endometriosis and ovarian suppression of the hormones, and mostly the estrogen, and it is the estrogen reproductive group, and it is estrogens are produced in this reproductive group. Then comes we will discuss with the medical treatment, and then comes the surgical treatment. No RCTs have so far been advanced before the medical treatment is tried, and the medical treatment consists of what you can say, this is COCP, combined oral contraceptive pills. These are given in a routine form, and then they are given continuously, where this main thing is the ovarian suppression, and the side effects of these hormones are there. And then comes the medroxyprogesterone, and this is also given subcutaneous and intramuscular. And then comes the COCP, intrauterine Mirena intrauterine device, which is fixed, and then release the progesterone wing, which are not only used as contraceptive, but also it finishes the irregular menstruation, heavy flooding, and the clots. And then endometriosis, I have told that it is basically the endometrial tissue which is present outside the uterus and elsewhere in the body, the sites which already has been mentioned. And then comes the Mirena intrauterine system, and then the danazol. Danazol also very effective in controlling them. It is an anti-estrogen, and it has got the side effects, and it produces acne, baldism, and irreversible changes in voice. Also suppresses the ovarian suppression and estrogen suppression. And then comes the GnRH analogs, but they have been used mostly for the because this has the potential ability for recurrence, so these are used for recurrence of the endometriotic lesions. So they are given, but they must be given with add back therapy, otherwise the bone mineral density is affected. So with the increasing use of fractures due to low estrogen. GnRH analogs and the aromatase inhibitors, they are also very effective in treating this endometriotic lesions, but they also have the side effects, and especially the cyst and the other things as well. This endometriosis is present in before the menarche as well, and may be reported in men as well, but it's controversial. And then comes the about the and we have mentioned danazol, aromatase inhibitors, COCP, medroxyprogesterone, and the GnRH analogs. With the GnRH analog, irregular bleeds and depression and vaginal dryness and all others, and bone mineral density and increasing fractures due to lack of estrogen and reduced BMD. And then regarding the surgical treatment, as no RCT has so far been shown, and when there is too much recurrences with the GnRH analogs and the other failed medical treatment, then we have to have a surgical treatment. And the surgical treatment are, as I have mentioned, removal of the lesions in the pelvis through laparoscopy, endometriomas, and the chocolate cyst. They are all removed laparoscopically. And also we have the if all these measures they fail, this improves the subfertility in mild to moderate, in mild to minimal to mild endometriosis, but for improve the subfertility, but for moderate to severe infertility there is no proven efficacy for it, and that has to be referred for IVF and ICSI. And then comes the last of all, when all these measures they fail, laparoscopic, all these endometriomas, endometriotic cyst, and the medical treatment, then we have to have the option of, if the family is complete and age is more, so we can have the total abdominal hysterectomy, and bilateral sulfingo-oophorectomy is also an option. And for the bilateral sulfingo-oophorectomy, you have for endometriotic cystectomy is to be done instead of drainage, because there is an increased chance of recurrence, and this also helps in relieving the as I have told, in minimal to mild endometriosis, the subfertility is improved. Subfertility is improved, and there is increased chances of conception. But for severe and moderate endometriosis, we have to refer for artificial reproductive techniques. And then, considering all this, a brief review of endometriosis, though it is a severely patient present with chronic pelvic pain, severe dysmenorrhea and dyschezia, and this chronic pelvic pain and cyclical discomfort of and hematuria, and all these bowel functions, they are disturbed present with bleeding PR, as the lesions in the rectus sigmoid they bleed, also in the bladder presents as hematuria. This subfertility is the main cause, and chronic pelvic pain. And for all other investigation, in another cause, in the investigation of the dysmenorrhea, which is dysmenorrhea, irregular menses, and heavy flooding, they are all treated by these mentioned drugs, which are COCP, which is danazol, which is medroxyprogesterone, GnRH analogs, and aromatase inhibitors, and also the medroxyprogesterone and aromatase inhibitors. So we will come with another review. Till that time, just it's a very common topic discussed, and it's going to very common in the reproductive age group, and we'll be discussing it's in detail later on. And we takeaway lesson is pray, praise, trust, love God Almighty Allah, and follow Rasulullah sallallahu alaihi wasallam, and we must not forget our glorious past. Allahumma ajirna minan nar, Allahumma zikrak shukr husn ibadatak, and ala bi zikrillah tatmain qulub, and we must always ask from the God Almighty who can solve all our problems. So हम तो माइल बकरम है, कोई साहिल ही नहीं, राह किसे दिखलाए राह भरे मंजिल ही नहीं. So we'll come with another review. Till that, thanks for the patience listening, and thank you very much. Best wishes and regards. Assalamu alaikum, jazakallah, and wama alayna illa al balagh.